Okay, guys, so just let me know if you can see the full screen. Are you able to see the full screen, guys? Everyone? Okay, you're able to see the full screen, right? Great. So today we are talking about myocardial infarction. Okay, myocardial infarctions called MI, also known as heart attack, right? Also known as heart attack. So today we will be discussing the ECG in myocardial infarction, right? ECG in myocardial infarction. So let's start with this. Identify the cardiac condition through ECG. Okay. Yes, guys. Looking forward for multiple answers. Find out what is the problem. Yes. Yes, guys. Tell me what is the problem. Everyone? Anything? Any idea? Through this ECG. STEMI. Okay. Very nice. Very nice, Prisha. Then anyone else? Yes, guys. Take your time. You have 1 minute. Think of like what it could be. After a long time, we are having the class. We have talked about bradycardia, tachycardia, heart rate, everything. Types of ECGs, everything. But this is something new. Yes. Anyone else who wants to put a comment on this? Prisha, how do you think it is STEMI? For you, all of you guys, STEMI is ST elevation myocardial infarction. Okay? I'm talking about the full form of STEMI, not the ECG. Full form of the STEMI is ST elevation MI. So how do you think, Prisha, that this ECG is STMI? Hmm? ST elevation. Tell me first, guys. Yes, ST segments elevated. In which lead? Please tell me which lead? 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Where ST elevation you can see? Tell me, where did you see the ST elevation? Yes, people. Anyone else who wants to put a comment on this? Prisha, one more question. You have which lead do you see ST elevation? Yes. Anyone else who wants to put comment on this? No idea? Okay. I'll not tell this right now. We'll come back to this. Okay. We'll come back to this. So let's discuss with the case. I'm today here to discuss a
So
case.
happy birthday. Thank you so much.
Array,
Ten,
whose birthday is that?
ten,
Please keep your mics on your mics, Junaid and
okay.
Deepchand, your mics. Yes, guys. Okay. So we are having a case of 39-year-old man present to the emergency room with 8 by 10 substernal chest pain and pressure radiating to the left back that has been occurring for last 9 hours. Okay. His cousin died at the age of 46 due to MI after 1 year of angioplasty to LAD. And this guy has been on lipid lowering agents and bisoprolol for past 8 months. Okay. So can someone tell me what could be the provisional diagnosis for this patient? Any one of you, guys, Can someone tell me what is the provisional diagnosis for this patient? Read it again and tell me the provisional diagnosis. Everyone, don't disappoint me. Yes, guys. All the logics are written on the slide. What could be the provisional diagnosis for this patient? Yes, guys, come on. MI, myocardial infarction, because we are studying myocardial today. So everyone, no, myocardial infarction is very general. MI, okay. MI, okay. MI, fine. Full provisional diagnosis. Can someone write the full provisional diagnosis? Please help me finding the full provisional diagnosis of this patient, guys. Yes, everyone. Full provisional diagnosis. Come on, you all are interns, right? Almost interns, and many of you are actually the interns, PharmD interns. Give me the provisional diagnosis, guys. Acute coronary syndrome. Okay, Soptic. Acute MI, Siddharth. Very nice. What makes you to think acute MI? Coronary artery disease. Hmm. Okay. What are the problems here? What are the evidences you feel it is leading to acute MI? Evidences, please. Signs, symptoms, history, whatever. Like, what are the evidences which are leading to risk factors, whatever are leading to the ACS? Yes, left side pain for 8 hours, 9 hours. Okay. Who is Da O Hipaya? Please change your name.
Reading class.
Yes, who is Da O Hipaya? Lying Do. Please change your name.
Yes, sir.
Yeah. Yes, guys. So tell me, family history is there, increased lipid levels. Okay. Left side pain in 9 hours, strong family history, chest pain, increased lipid levels. Okay. And please keep the mics off. Keep the mic off. Okay. So, yeah, family history, and he's also on the lipid reducing medicine as well. Okay. Fine. So, what is the complete provisional diagnosis? Again, what is the complete provisional diagnosis? Guys, tell me. It is very simple. Why are you taking so much of time? Why are you taking so much of time? Maybe STEMI. Okay, fantastic. Array, provisional diagnosis, full provisional diagnosis. First of all, okay, maybe ACS, acute coronary syndrome, you guessed, right? Because there is there are risk factors, there is a family history, and the continuous chest pain. Okay, continuous chest pain. Fine, you can say it is acute MI. Provisional. But along with that, full provisional diagnosis is acute coronary syndrome, hypertension, and hyperlipidemia. Understand? Hypertension, hyperlipidemia. That also is there. Hyperlipidemia because he is already on the drugs for high lipids, high blood pressure, right? So the full provisional diagnosis is hypertension, coronary artery disease, and hyperlipidemia. Okay, understand? Now, lab investigations. We are not going to that because we are reading. We are in the study. We are in the ECG class, right? But still, CKMB 300 at the higher level, CKMB 25 higher level. Okay, troponin T 0.88 very high, NT-proBNP very high. Cardiac biomarkers are indicating towards myocardial infarction. ECG. Look at VF and ST depression in V5, V6. Can someone tell me what is this? Can someone tell me what is this diagnosis after seeing the ECG? Yes, people, what this ECG shows? Can someone tell me what this ECG shows? STEMI? Sinus rhythm with small Q waves in lead 3, AVF with T wave inversions in 2, 3, AVF, and ST depression in V5, V6. Let me make it visible. V5 visible. ST depression, whole ST is going down. See here with my cursor. Let me show you with the cursor pointer. Okay, pointer, laser pointer. See here. See this. ST depression V5, V6. ST depression in V5, V6. ST depression in V5, V6, right? ST depression. Okay, and T inversion in 2, 3. T inversion, T inversion, T inversion, T inversion, T inversion. T inversion in 2, 3 and AVF, 2, 3 AVF. T inversion, right? This is T inversion. So this is definitely this is not ST elevation. This is ST elevation absence. Okay, absentia of ST elevation because ST depression is there here. ST depression is there in almost all the leads, all the frontal leads. Okay, so it is could be an STEMI. Okay, an STEMI. Now, guys, again for your assessment, what is this? You were telling STEMI. Check V5 ST depression, proper notable ST depression. V6 notable ST depression, notable ST depression. Look at second, third ST depression, ST depression, AVF, ST depression, ST depression. So what is this? This is also an STEMI. This is also an STEMI. Okay. Understand? The first slide, first ECG was also an STEMI ECG. Okay, an STEMI ECG. Now, how to differentiate? Let's go to differentiation. So, this is the normal ECG, what we have learned in last classes. And this is ST segment. This is T wave. If the ST is going below ISO, what is this called as? What is this line called as? ISO. What is this line called as? Yes, guys. Or you forgot? What is this bar called as? Isoelectric line. Okay. Okay. Suppose isoelectric line. Anyone else who knows? Isoelectric baseline. Okay, fine. Isoelectric baseline. So if the isoelectric baseline is going down, that is called ST depression. And if the T wave is going down like this, that is called T inversion. These are the types of ECG deviations. And if this goes from here only, it goes high, that is called ST elevation. Okay, ST elevation. If the ST goes high, that is called ST elevation. This is ST elevation, this is ST depression, this is T inversion. Okay, these are the three prominent representations. And here you will be sometimes Q wave, not prominent but Q wave. PQRST, sorry, Q wave, you will see here Q wave also. Okay, Q wave, upright Q wave. Okay, here you will see upright Q wave also, but very, very, very less in very specific regions. Okay, I'll tell you that. Right, but you have to focus on three things in MI. Whenever you're looking at MI, either ST elevation, right? ST elevation from here, or ST depression, or T inversion, right? Either of these, or maybe combination of ST depression and T inversion. Against, maybe there would be ST elevation, right? So this shows. So whenever you see, like now see next slide here, very important difference of ECGs. Look at this, guys. This is ST segment, normal ECG, P wave, and this is QRS complex, P wave, QRS, right, and T, right? This is QRS complex, normal QRS complex, normal P wave, normal ST, normal T wave, right? Normal T wave. This is normal ECG. And when it comes to an STEMI, or suppose STEMI means ST is elevation. So ST elevation, see, isometric bar, isometric line, isoelectric line, the bar should be here, but it is completely elevated. Okay, it is elevated usually more than 2 mm. Okay, it is elevated more than 2 mm usually. Okay, 2 mm, right? Remember this 2 mm, it will be helpful in the understanding the next slides. Okay, 2 mm ST elevation, that is called STEMI, ST elevation myocardial infarction. Again, against ST opposite, there is another type of MI, that is an STEMI. There are two types of pattern, either ST depression, again isosometric, or isoelectric bar is here, isoelectric line is here, depressed, ST has gone down, that is called ST depression. Okay, if not ST depression, they will be T inversion. T would be downward, T inversion. These are the representations of an STEMI. This is STEMI, this is an STEMI. This is STEMI, this is an STEMI. Right. So these are the common types of myocardial infarctions. But usually ACA, usually the CAD, coronary syndrome, the coronary artery disease or acute coronary syndrome is divided into four types. Okay. One is stable angina, where there is a pain, but ECG is completely normal. Okay, pain goes and comes and goes. Okay, pain comes and goes with the rest. Okay, with the rest, troponin T is normal here, and ECG is also normal. But it does not mean that there is no clot. There is a clot, high demand of oxygen, demanding ischemia, but infraction has not happened yet. That is called as stable angina. Okay, unstable angina means infraction has not happened yet, but there is something more. Thrombus is started forming. Thrombus is started forming here in unstable angina. Stable means here it goes off with the rest and it is not an urgent. Okay, it is not an emergency. But unstable angina could be emergency because the clot has formed here. Thrombus has formed. It could be burst anytime. Okay, and the demand of oxygen is very high and supply is very less. Right now there is no infarct, but it can happen anytime. In that case, your ECG could be normal or maybe T inversion or ST depression. STEMI symptoms, okay, STEMI representation would be there. TROP-T could be normal, okay, TROP-T could be normal in such cases. That is called unstable angina. Then anstomy, where you're again the same thing, ST depression, inverted T waves, okay, anstomy, and here plaque is ruptured, and troponin T will be elevated, but ECG changes, you will see ST depression or inverted T waves. Unstable angina also means symptoms like or representation like anstomy. Stomy is like your hyperacute T waves or ST elevation. T waves, hyperacute T wave or ST elevation. Right. So this you will see here again transluminal infarct has happened, and it is one of the very dangerous things. So not only this, but all three, unstable angina, STEMI, and these all three. Someone's mic is on, guys. Again, check your mics. Rang, your mic is on, rang. Okay, so these all three are called ACS. Okay, these all three are acute coronary syndrome, and this all combinedly all four are coronary artery disease. Okay, out of these, unstable angina, STEMI, and anstomy, these are acute coronary syndrome, right? And these are the differences between ECGs, right? So ECGs are changed in unstable angina, STEMI, and I mean non I mean anstomy, right? So anstomy and unstable angina shares the same symptom, share the same representation in ECG. STEMI shares the different representation where it is ST elevated or hyper acute T waves. Okay, let's see now. So what was the patient here? For the test been done like angiogram. Angiogram showed the blocks in right coronary artery also, and multiple blocks or multiple thrombus in the left side, right? LMCA complete occlusion, LCX occlusion, and LAD occlusion, and the final diagnosis was dyslipidemia, hypertension, acute coronary syndrome, iron deficiency anemia could be, and contrast induced nephropathy, because this your the patient's creatinine was high. Okay, but that is not our concern right now. Our concern was ECG. So I hope you understood. Okay, guys, did you understand the basics of myocardial ischemic, myocardial ischemic ECGs? Did you understand the STEMI and anastomy, and difference between STEMI and anastomy and normal ECGs? Did you understand the basics? Any questions here? Any questions till now? Because now we are diving into the more complex things of ECGs. Any questions till now? Okay, so now question is here. What is the ECG says? What does the ECG says here? What is this ECG? Yes, people, fast. Tell me. What is this ECG? Complex? Is it complex? Yes, guys. You should have not taken 10 seconds to this. 10 seconds, I'm telling you. Because this is the same ECG from the first slide. This is the copy of the first slide only. The first ECG what I asked is this. Okay, this is the same slide. I copied and pasted. Anastomy. Identification in the ECG doesn't take time. Okay, just seconds, within seconds. This is the same ECG I showed. See, you don't have to look into the whole ECG. You just check. When we are talking about myocardial infarction, you should check just okay, 2, 3 AVF 456, 2, 3 AVF 456, 2, 3. Okay, 2 ST depression, 2 ST depression, 3 ST depression, AVF ST depression, 4, 5, 6 visible ST depressions, anastomy. Over. Just 2 seconds, guys. Just 2 seconds. Okay. Now, this is anastomy. ST segment depression, T wave inversion, no persistent ST elevation. So it is anastomy. Okay. So here you can see there are three types of ST segment depression. You will see, right? Either this upsloping. This is also ST segment depression. Downsloping is also ST segment depression, and horizontal is also ST segment depression. You don't have to think like, okay, this is not ST segment depression, this is not ST segment depression, this is not ST segment depression. There are three types of ST segment depression, and you will see it and you will say, okay, this is ST depression. Anything below the isometric or isoelectric line is depression. It's very simple to understand. Anything below isoelectric line is ST depression. And you must practice it, otherwise you will not understand. This website is fantastic website, I'm telling you. I'll give you some references in that. These are mind-blowing websites to read for you. Easy to understand websites. Okay, so this is ST segment depression. Okay, now identify this cardiac condition through ECG. Yes, guys, what is this? I'm making you practice here also. Tell me. What is this, guys? Come on, fast, fast, fast. Tell me, I'm looking for answers. Fast, don't take much time here, guys. Come on. What is this? What is this? What is this? Check, everyone. Are you understanding? People are not replying. If you're not replying, means you're not understanding at all. Only two, three people are understanding and replying. Why not everyone? Or you are just, if it is going above the head, then please tell me. Anastomy, anastomy. Anyone else? Anastomy. Okay. Anyone else? Fantastic. Anastomy. This is anastomy. Again, see, look at this. Second, third. ST depression. Okay. T inversion. Sorry. Here, this is not ST depression. This is T inversion. T inversion. Okay. This is elevation, but not persistent to, no persistent to, leads. Okay. So T inversion, Q4, I mean V4 T inversion, V5 T inversion, V6 T inversion. So at least two continuous leads, it should be T inversion or ST depression, right? Here it is in V4, V5, V6 T inversion, and second also T inversion, right? Third, no T inversion, right? But in AVF also, somewhere it looks like T inversion, okay? Not similar to third. If it is like similar, then it could be something else, okay? If it is like third and AVF are having similar pattern, and V4, V5, V6 have the similar pattern, then it could be something else, okay? But right now it is T inversion, so it is again an STEMI. Okay, T inversion. This is not ST depression like previous ECGs. This is T inversion. Okay, this is T inversion. Okay, got it? STEMI. Now, next ECG. Sorry, this was STEMI, right? This was, oh, sorry. Okay, fine. We were talking about STEMI. This is, we were talking about anastomy. This is STEMI. Okay, this is STEMI. I think I uh, did the results first and ECG later, but that's okay. See, I'll come to this later. Okay, or let's do it. See, you will see ST elevation. See here, ST elevation V4, ST elevation V5, ST elevation V6, right? ST elevation V2, ST elevation AVF. And here also ST elevation is not there, but T is normal, even no suppression, no ST depression, right? But here prominent in the two, ST elevation, AVF, ST elevation, V4 ST elevation, V5 ST elevation, V6 ST elevation. So more than two contiguous leads, contiguous means continue leads, more than two contiguous leads, ST segment is elevated. ST segment is elevated in two contiguous leads. Okay. And then reciprocal ST segment depression in opposite leads. Opposite leads means, look at this, AVR. AVR ST depression. AVR ST depression is there. Okay. Proper ST depression. V1 ST depression. Okay. So ST depression is there in the opposite leads, and hyperacute T waves. Hyperacute T waves. See, look at this. Hyperacute T waves means ST ST segment is not at all visible from the end of S only. The T wave is going very high, right? So hyperacute T wave is very high, right? So this ST elevation, T is elevated from here only, so that is called hyperacute when it is largely high. Okay, when it is largely high, this is called hyperacute T wave, right? Pathological Q waves, somewhere you will see pathological Q waves also. Yeah, see here. After P, the Q is going down here, not exactly at the, it is very lessly visible or not notably visible, but here there is a consequent, separate wave. Okay, after T, there is after P also there is a subsequent wave here. See, this is PQ, right? Here, subsequent wave, but this is not usual Q, right? So sometimes pathologically Q wave appears in sometimes V7, V8 and V9. Okay, V7, V8, V9 are reflecting in V1, V2, V3. Okay, when I say V7, V8, V9, that reflects in V1, V2, V3. Okay, V7, V8, V9 is reflection of V1, V2, V3. Okay, so we can see here V1, V2, V3 are the reflection of 7, 8, and 9. Okay, so here this is STEMI clearly ST elevation, hyperacute T wave. Okay, ST elevation and hyperacute T wave in more than two contiguous leads. Okay, so now next is what is this, guys? Tell me this. Think of, don't just write STEMI. Okay, look at this, go back to your classes, and then let me know. Okay, yes, guys, think of properly, then let me know. Take 1 minute of time. Yes, what is this ECG? What is this ECG, guys? Yes, please check and tell me what is this ECG? Start writing your answers, guys. Yes, guys, now answers. Anything? Your answers? Anstomy. Okay. SD. What is the full name of SD? Anstomy. Okay. Okay. Anyone else? What is this, guys? Someone has told anstomy. Okay. Very nice. Ria also anstomy. SD anstomy. Other people? Yes, guys. Can this be block looks like irregular RR interval? I don't know. I'll tell you. I gave you a hint. Go back to your past classes and use today's class. This is the combined effect or result of your two classes, today's and last classes, what you attend in Arrhythmia. Tell me. The people can change the answers now. Tell me, guys, what is this ECG? What is not understanding? Why you are not understanding? Please speak. I want to see. I want to see what are the problems you are facing. I have written something, the hint in your chat box. LBBB. Yes. Yes. One right answer, LBBB. But this is from the past. From today's class, from today's class, why it is not RBBB? Tell me. Why it is LBBB? Yes, guys. Why it is LBBB? Soptic and Rang. Rang, tell me. Why it is LBBB and why it is not RBBB? Come on, guys. It's very simple. Yes, people, come on. Other things. Okay, let me tell you. See, first of all, people were telling anstomy. Look at the second. What is this? This is ST depression. This is also ST depression. This is also ST depression. Right, guys? Right? These are ST depressions. So you are telling anstomy like RIA and SD. Right? You are telling ST depression. That's why you are telling anstomy. Correct? Yes or no? Come on, guys. Wrong. This is this is this is reverted QRS complex and this is elevation. This is elevation. This is ST elevation. This is ST elevation. This is ST elevation. So this is ST elevation. And here, if you look at clearly V4, V5, V6, this is ST elevation. This is ST elevation. Okay. This is also ST elevation. This is clearly ST elevation here. QRS, ST elevation, QRS, ST elevation, QRS, ST elevation. This is QRS, shorten QRS, QRS, ST elevation, QRS, ST elevation. And how you can make it? See, this is MW, this is WC, QRS complex W, right? You can see easily W here and M here. See, your this is making M. Okay, this is QRS and it is making M here. Okay, it is making in V1. It is usually in V1 and I'm sorry, first. It is first and V1. It is making M here. Okay, see here clearly M. After QRS only it will make M, right? QRS complex is this. This is making M here and this is ST elevation. Understand? This is making M here. This is ST elevation. Look at the V5, V6. This is making W here. After QRS, this is QRS complex and this is making this. You cannot count like this. It is M. No. From QR, R to S, if you see, this is making W here. This is making clear cut W and this is ST elevation. See, that is the, you have to be very sharp when you are reading ECGs, guys. When you are reading ECGs, you have to be very sharp. This is not tough at all. I'm telling you, you just have to see clearly. See, you cannot say that your largest thing is QRS. No. See, look at this starting point. This is the starting point. This is the starting line of V4, V5, V6. From here, check it. This is QRS complex. This is QRS complex. If QRS complex means this is Q, this is R, this is S, right? So we will count W from RS, right? So it is W. We will see after RST, right? Then we will see what it is making. It is making clear cut W, right? It is making clear cut W. And after RS, T is going very high. This is T elevation or ST elevation. You can see clear cut ST elevation. W plus ST elevation. W plus ST elevation. W plus ST elevation. W plus ST elevation means this is LVBB plus STEMI. LVBB plus STEMI. Okay, this is LVBB and STEMI. Understand? See, look at this. Hyperacute STEMI. Hyperacute STEMI. You will see there are hyperacute T waves in V2 and V6. V2 to V6. See, hyperacute T waves. These are hyperacute T waves. Hyperacute T waves. Sorry, hyperacute T waves. Hyperacute T waves. Hyperacute T waves. Okay, V2, V3, hyperacute T waves. Hyperacute T waves. These are T waves. Hyperacute means very high T waves, and because of that loss of R wave, that's why you are not able to see the R is small here. R is not always on the high level. It's not necessary. Okay, it should be at the same location. It should be at the proper location in the representation. That's enough. Okay, so this is R wave height is very less and hyperacute T waves, right? There are premature atrial complexes which goes towards LBBB. Okay, multifocal ventricular ectopy is going towards the LBBB. You know, multifocal ectopics, these are multifocal ectopics, and this is this is MW, pattern also LBBB. So this is LBBB plus S STEMI. Understood or not, guys? Tell me. If you don't understand, tell me. Did you understand or not? Did you guys understand or not? If you not understand, I'll repeat it again. Please tell me. But you have to be very sharp to understand these things, guys. You cannot get confused. Every person will not have the same ECG, okay? This much, this much, this much, this much. ECGs are changed with every person, okay? But the pattern you have to check. Pattern is same in everything, okay? So this is hyperacute anterior STEMI. Anterior also you will come to know, okay? But right now this is LBBB plus STEMI, okay? Now, what is this, guys? Yes, what is this? Oh my God, trauma for you. I can say this is trauma for you. What is this? Tell me, what is this, guys? No hints. Tell me what is this? STEMI. How STEMI? How STEMI? Ventricular tachycardia. Fantastic. Ventricular tachycardia. Fantastic. Very nice. Tachycardia, ventricular tachycardia. First of all, let me give you a hint. This is not a class of tachycardia. Okay. This is not a class of tachycardia. Tell me what is this? What kind of structures you are able to see here? Tell me. Mountains, tombs. What kind of structures you are seeing in this ECG? M shape. Why STEMI? M shape. Okay, guys, any guesses? Any more guesses? What is this ECG? Maybe related to electrolytes. But today we are not talking about the electrolytes. Okay, let it be. Okay, so let me tell you a little bit. See, from here, this is the starting line. This is the starting line. V4, V5, V6. Look at this. This is the starting line. This is QRS complex. This is QRS complex. This is ST elevation. This is hyperacute T wave. This is hyperacute T wave. This is QRS complex, completely invisible. Here also look at this. This is like, see here also. This is hyperacute ST elevation. Hyperacute ST elevation. ST elevation or T elevation. Hyperacute T. You will see hyperacute T. So definitely it is STEMI. Definitely it is STEMI. But there is a pattern, as I can say, this is tomb-like structures. So this is called tomb stoning. Tomb stoning. And why it is and what it is? This ECG comes in massive anterior STEMI. Massive means the massive heart attack where mostly deaths are the end. Like patient dies within seconds. This is STEMI, but massive STEMI. If you see the ECG like this, patients will not survive. or maybe 1 or 2% patients survive in this case. This is hyperacute T wave. Okay, so let's see what it says. This is extensive anterior MI, tomb stoning pattern, massive ST elevation with tombstone morphology is present throughout the precordial 1 to 6, V1 to 6, and high lateral leads 1 and ABL. This pattern is seen in proximal LAD occlusion, 100% occlusions of LAD, and patient dies. Okay, indicates a large territory infraction with a poor LV ejection fraction and high likelihood of cardiogenic shock and death. Okay, so this is the sign of death in STEMI in heart attacks. If you see a ECG like this, that means it is tombstoning pattern of massive ST elevation MI. Means the severe heart attack, massive heart attack, means a large part of your LAD, left ascending descending aorta, sorry, left ascending descending is gone. Okay, LAD is gone. Okay, completely, it is a very severe case and it leads to the cardiogenic shock and death. This is STEMI only, but massive STEMI. Okay, understand? Yes or no? Understood or not, guys? Did you get it? There are many things what you can learn, but please go and learn. Practice it. Okay, there are hundreds of ECGs, thousands of ECGs you will get, but learn each and everything, then only you will be expert. ECG and you are like AI and ML. You should be, as much as ECGs you will see, you will be trained, you will be giving good outcomes, you will be giving good predictions. Okay, so you are the machine right now for the ECGs. Okay, you have to be trained in each and everything. Whatever number is increase, your knowledge will increase. Okay, I'm telling you, I have seen thousands of ECGs in my PhD and afterwards, and now also, wherever I get a chance, I go and check at least 10 ECGs per day, 10 ECGs per day. And still, I say I'm not expert of ECGs. But you should learn it. If you want to survive a little bit in the clinics, you should learn ECGs because ECGs is the very primary thing to get in emergencies or in any aspect. ECGs are done because we always care about heart. We always check the cardiac thing. So we do that, right? So this is here, right? ECG changes with heart anatomy. So wherever you will see these things, these are common, right? The leads, when we say inferior MI, there'll be the same changes, elevation or depression in lead 2, 3 AVF. Majorly inferior MI, you will see the changes here, 2, 3 AVF. Okay, posterior MI you will see in the V1, V2, V3. Posterior means the posterior, usually it comes from the mid-axial and actually V7, V8, V9, these are showing reciprocal changes in V1 and V3 you will see. Okay, posterior MI. Anterior MI you will see V2, V3, V4. Lateral MI you will see major changes in V5 and V6. Septal MI means between the any chambers. If the myocardial infarction or the infarction is happening between the septals, that will be reflected in V1 and V2. Okay, and this website thoracic key is amazing to learn it. Okay, there are ECGs, multiple ECGs, and you will see that. Okay, so inferior MI, posterior MI, anterior MI, lateral MI. So let's see, let's check. You look at this and remember, try to remember in next two exercises. Try to remember this. Let's see how much you remember. Inferior MI 2, 3 AVF. Posterior MI V7, V8, V9 reflecting in V1, V2, V3. Anterior MI V2, V3, V4. Lateral MI AVL V5, V6 and first. Septal MI V1 and V2. Okay? Understand? Let's see. Tell me what is this. And even it is, see, you can see the square also. This is denoted. Still, if you find out, I'll see. What is this, guys? Yes? What is this, people? Location wise, which MI it is? Tell me. Which MI it is? Do you remember? From the last slide only. Come on. Say me fast. Third and AVF. Inferior MI. Inferior wall MI. It is inferior wall MI? Okay. Inferior wall MI. Perfectly fine. Inferior wall MI. Very good. Very good. Now tell me this. What is this? V2. V2. What is this? Anterior wall MI. Is it anterior wall? It is anterior. Anterior wall MI. Okay, this is anterior wall MI. Perfectly fine. This is anterior wall MI. So you should be very, very, sharp in that. Go to this website. I have taken this material from this website. Thoracic key, the ECG in patron in the patients with chest pain too. Okay, thoracic key. This is a fantastic website. I also have taken the material from that to teach you. It is amazing. Literally, I'm telling you all the types of ECGs you will see there. Okay. So guys, thank you for today's class, and we are done with the MI. That much I wanted to tell you. And tomorrow I'll be taking in specific vulnerable populations, and day after tomorrow topic you tell me what else extra you want to learn, and then we will end the ECG program. Then we are done with this basic course. Okay, and then I will have an exam. You have to give, right? So you guys tell me what else you want to learn in the Wednesday class. Guys, tell me. You want to learn something else in Wednesday class, or you want to revise me something? Please tell me now. Revision. Okay. Revision. Okay. In detail about heart block, first, second, and third degree. Okay. Revision. Okay. Revision. Okay. Revision. Fine. I'll take a revision class on Wednesday. Okay. I'll take a revision class on Wednesday. Fine. Cool. And tomorrow in specific populations. So today you understood or not? Today's class. Okay. Did you get it or not? Okay. Fine, guys. Fine. Thank you very much. Then, okay, fantastic. Then we'll wind up now. If you don't have any questions. Sir, diploma certificates. What diploma certificates? I'm not getting it. Diploma certificates. Is electrolyte in ECG done as I don't attended last class? No, electrolytes in ECG don't. No, no, no. Today, no feedback because I forgot to share the link in interns. So no feedback form for today. Okay, guys, don't worry. Diploma in pharmacovigilance, message me personally or message to our other number. Okay, then we'll solve it. Okay, guys, thank you and take care. Good night, guys. Good night. Have a good food. Bye bye. See you.